medical review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. If you haven't yet subscribed to the channel, please help me out as we are on the road to 1,000 subscribers. To hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. And grab your piece of paper, grab your pen, and let's go. Today we're going to be discussing about hypertension. So now, before we actually go into the meat of the discussion, there are a few physiological terms that I want you to know. The first thing that I want you to know is what blood pressure is. So remember that blood pressure is pretty much a product of cardiac output multiplied by your total peripheral resistance. And where cardiac output is the amount of blood that is going to be pumped out of each ventricle in a minute. Remember that the normal cardiac output is 5 liters per minute. And how exactly do we calculate cardiac output? We say the stroke volume multiplied by the heart rate. And remember that the stroke volume is the amount or the volume of blood that is pumped out of the heart with each contraction. And remember, each contraction pumps out about 70 mils of blood. So it means that half of whatever is in the ventricles, roughly around 140 mils, half of this is going to be pumped out when the heart contracts. So the stroke volume is about 70 mils. And remember that the heart rate is between 60 to 100 beats per minute. So remember that cardiac output is a product of stroke volume multiplied by heart rate. And then the cardiac output is going to be equal to 5 liters per minute for each ventricle. And remember that blood pressure is a product of cardiac output multiplied by total peripheral resistance. So in essence, you can think of blood pressure as cardiac output stroke volume multiplied by heart rate multiplied by total peripheral resistance. Let me just show you a blackboard here so that I can successfully beat this point to death. So I will let's use blue. So we have our blood pressure here. So I shall call this BP. Remember that blood pressure is going to be equal to cardiac output multiplied by our total peripheral resistance. Remember that the total peripheral resistance is just simply the resistance, or rather the force that is offered to impede or to stop blood from flowing. So this is usually brought about by the arterioles. These are known as the resistance vessels. Okay, so this is just the force that impedes or slows down the motion of blood. And remember that cardiac output here is going to be equal to the heart rate, okay, which is roughly around 60 to 100 beats per minute, multiplied by your stroke volume, which is the volume of blood that is ejected from each ventricle with each contraction. Then, so in essence, our blood pressure is equal to our heart rate multiplied by the stroke volume multiplied by the total peripheral resistance, or TPR. So if the heart rate increases, so if we increase the heart rate, like for example, if you're anxious and you're expecting to receive some test results, it will mean that our blood pressure is going to increase. If we increase our stroke volume, if there is a lot of retention of water in the body, it means that our blood pressure is going to increase, because all these things are directly proportional to each other. If we increase our total peripheral resistance, so it means that if the arterioles constrict, this is going to lead to an increase in blood pressure. So an increase in either of these factors is going to result in an increase in blood pressure. And understanding this will understand why hypertension can arise, because sometimes hypertension may arise due to retention of water or retention of sodium that usually goes with water. So it means our stroke volume is going to increase. And if our stroke volume increases, it means our blood pressure is going to increase. Sometimes it may be due to a vascular disease where the tone is not really regulated so well and the blood vessels are contracted such that there is an increase in peripheral resistance. And if we increase our peripheral resistance, it will mean that our blood pressure is going to increase. And then obviously, if our heart rate increases, the blood pressure is also going to increase. There are also other factors that you are supposed to be wary of, which I will draw a heart over here in the form of a square. So or an oval, whatever it may be. So I would divide this into 4 chambers like that. Remember that there's blood that is going into the heart. Okay, so the amount of blood that returns to the heart, you refer to that as the venous return. Okay, so this venous return is largely dependent on the veins, because remember that the veins have specialized systems in which allow blood to reach back to the heart. One system is that they consist of valves that are present inside them, such that these valves ensure unidirectional flow of blood. The other mechanism that is there is that these veins actually exist between muscles, such that if the muscles contract, they push the blood back towards the heart, which is referred to as a milking effect. The third reason is due to with the pressures. So remember that the heart is in the thoracic cavity and there's intrathoracic pressure. So if there's a decrease in intrathoracic pressure, it would mean that it's easier for blood to flow from a region of high pressure coming from the veins to a region of low pressure inside the heart. And remember, this usually happens when someone inspires, because there will be a fall in intrathoracic pressure when someone inspires. So it means that the venous return will be much more than as opposed to expiration, when the intrathoracic pressures are much higher and there's not so much blood that is reaching the heart. So that's what you refer to as the venous return. And remember that this venous return, or the amount of blood that is present in the heart before it contracts, is referred to as the preload. Okay? So the preload, you can think of it as the amount of blood that is going to be present in the heart before it contracts. And remember that this preload is largely going to be affected by your venous return. You can think of the preload as your end diastolic volume, or your EDV, end diastolic volume, which is pretty much the amount of blood that is present inside the heart ventricles before it contracts. And remember that our end diastolic volume is roughly around 140 mils. So if you have, at the end of diastole, you're going to be having 140 mils that are present within the chamber. And whenever this heart is going to be contracting and pushing out blood, about 70 mils of this blood is going to be pushed out. And this 70 mils is what we've already referred to as our stroke volume. So it means that the fraction of blood that is actually pushed out of the heart is 50%. So you should push out more than 50% or more of this blood from your heart. That you refer to that as your ejection fraction. So if you divide the stroke volume divided by your end diastolic volume, you get a percentage or a fraction. You refer to that as your stroke volume, or rather your ejection fraction. Then preload is largely also going to affect the cardiac output. I will explain that very shortly. But remember that this blood that is now in the heart has to be pumped out back to the head and the body. And remember that the blood vessels to which this blood is going to be conducted offer some resistance to the flow of blood. So this resistance that is offered to the flow of blood is referred to as the afterload. So you can think of the afterload in the same vein as you think of the total peripheral resistance. So they pretty much mean similar things. When someone is talking about the afterload, they could also be referring to the total peripheral resistance. So it means that if the blood vessels are constricted, it would mean that the heart will have to generate a much greater force to overcome this resistance. So it means that the afterload is going to be much higher. If the blood vessels are dilated, the arterioles and the arteries are dilated, it means that the heart is not going to be carrying out, or rather generating a greater force to overcome this resistance, because the resistance is less. Now, the last principle that I want to explain is what is known as the Frank-Starling phenomenon. Now, I usually like to give an analogy to help explain this. So the analogy I usually like to give is this. Suppose you and I are in a department. Let's say we're in a department of medicine and we are lecturers. I'm the senior lecturer, of course, and then you are the junior lecturer. So let's say we administer a test to 200 students, and we administer this test on a Friday. And then we collect the scripts, and then I give you 20 scripts to mark, and the admin needs the results on a Monday. So if you get 20 scripts and you have Friday evening, Saturday, Sunday, 3 days, you'll be marking at a certain pace. Now, suppose on Saturday morning I come and give you 20 more scripts. Are you still going to be marking at the same pace? No. You're going to increase your pace because now you have more scripts to mark. Now, same case scenario. Suppose on the Saturday morning I come and take 50 scripts away and leave you with only 5. You still won't be marking at the same speed of lightening. You'll reduce your pace. But then suppose on Sunday evening, just when Monday is almost dawning us, and I come and give you 100 scripts and tell you that I need this marked by tomorrow, you're going to feel overwhelmed and you may not even mark them. So in the same way, the heart behaves in a similar fashion. So within physiological limits, the more blood or the more the myocardium stretches, okay? So the higher the preload, the higher the venous return, then the greater the contractility, and therefore the greater the cardiac output. So it means that stretching out of the myocardium within physiological limit will result in significant increase in the cardiac output. Of course, this is to a certain extent. If you exceed the physiological limit of the myocytes in the heart, there won't be any significant increase in the cardiac output. So that's your Frank-Starling phenomenon. And those are the principles that I want you to keep in mind as we're going to be discussing hypertension. Now, the last and final thing that I want you to learn about is, of course, the regulation of blood pressure. But as of this point here, I won't really bother you with much, but I shall cover it in the next video on internal medicine when we talk about heart failure. That's when I will talk about the regulation of blood pressure. So let's get back to the slides and see exactly what we have to say. So I've discussed what blood pressure is, what cardiac output is, what heart rate is, what stroke volume is, afterload or total peripheral resistance, preload or and diastolic volume. We've also talked of ejection fraction. We've talked of peripheral total peripheral resistance. We've talked of venous return. We've talked of the Frank-Starling phenomenon, and I will explain control of blood pressure when we talk about heart failure in the next video on internal medicine. So back to hypertension. Remember that hypertension is just simply a persistent elevation in arterial blood pressure. And remember, we're talking about systemic hypertension. We're not focusing on pulmonary hypertension. So what is this persistent elevation? What does it mean? If someone has a systolic blood pressure that is greater than 140 millimeters of mercury, or a diastolic blood pressure that is greater than 90 millimeters of mercury on more than one occasion, that's the catchword. Persistent elevation, and it should be on more than one occasion. So it should be 2 or 3 times that are separate. Of course, in pregnant women, we do not have that luxury of telling the woman to go home and come back the next week or come back another day. So we usually use hours. So we can split it into about 4 to 6 hours apart. So unless if an individual comes to you with complications of end organ damage, or what we refer to as target organ damage, for example, if they come in with a hypertensive emergency, or they come in with a BP that is greater than 210 over 115 millimeters of mercury, then you can make the diagnosis of hypertension there and then. But otherwise, you need at least 2 or more occasions that are different with a persistent elevation of the blood pressure. And note that an increase in diastolic pressure that's greater than 85 is actually been associated with an increase in cardiovascular morbidity as well as mortality. Now, when we look at the epidemiology of hypertension, we see that it is very, very common in individuals that are above the age of 60. It's much more common in black folks than it is in white individuals. Slightly higher in males than in women, but of course when they reach a certain age, especially in women that are above the age of 50, the incidence of hypertension is almost equal, and it's actually slightly greater in women because as women are approaching menopause, you get those hormonal changes that may predispose those women to developing hypertension. So another important note that you need to take notice of is that all the adults should be measured for blood pressure routinely at least every 5 years until they reach the age of 80, because sometimes individuals may not have symptoms. They may not know that they're hypertensive. So it may just be a coincidental thing that you find out that, oh, this individual, by the way, is hypertension, or is hypertensive. That's why it is referred to as the silent killer, because the majority of the times the individuals do not know that they have hypertension. So you should measure a seated blood pressure, and it should be measured after 5 minutes of the person resting. So the person shouldn't be anxious. They shouldn't be in any distress. They shouldn't be in any anxiety. And you should measure this 5 minutes after they are resting, and they should have an appropriate cuff size, and their arm should be sufficiently supported, and their arm should be at the level of the heart. You should also measure their standing blood pressure. this is very good, especially in patients who are diabetic, in elderly patients, of course, to exclude orthostatic hypotension. And then all healthcare professions or healthcare workers should know how to measure blood pressure. So I will explain to you the process of measuring blood pressure later on in this lecture. And any non-pathological rise in blood pressure is going to be seen during episodes of pain. It's going to be seen during episodes of anxiety. And most of the times there's something that is referred to as white coat hypertension. Now, white coat hypertension is just simply this rise in blood pressure that is often associated when you see healthcare workers, especially those that are wearing white coats. So if you see a doctor, you start to get anxious because maybe the doctor may tell you that you're not doing so well, or maybe the doctor may tell you that you're dying. Think of the time that you visited the dentist. I'm sure most of you can even start to feel the pain in your teeth. So you refer to that as white coat hypertension. It's not really a true type of hypertension, but however, if someone has these rises in blood pressure, it may actually signify an underlying problem, so you may consider to follow them up. So how do we classify hypertension? It can be classified largely into two groups. It can be classified etiologically into two main groups. It can be either essential, which is also known as primary. It's also known as idiopathic, meaning that there is no cause, or it can be secondary to a certain cause. And then we can also divide hypertension according to the degree of elevation of the blood pressure. So in brackets, you can think of this as the severity, where you could have people that are normal, people that are pre-hypertensive, hypertension stage 1 and hypertension stage 2. And there are some books which even go on and give you hypertension stage 3. So we'll begin with etiology. So like I already said, there are two types. There's essential, which is also referred to as primary. It's also referred to as idiopathic hypertension or secondary hypertension. Now with essential hypertension, which is the much more common, there's no word like commoner, much more common variant of the hypertension is going to be accounting for 90 to about 95% of the individuals. And remember that this is multifactorial. It has been linked to various genetics. It has been linked to various environmental factors. It has been linked to even age. And most of the times, most patients that have essential hypertension or idiopathic hypertension are often less than the age of 30. So there may be some genetic factors because it tends to run in families. So it means that when you're taking your history, you should ask if there is a family history of hypertension. There are also some fetal factors that have been associated, especially in babies that are born with low birth weight. So it is actually believed that a fetus undergoes some fetal adaptations, especially inside the uterus when they are undernourished. And when this happens for a long time, there are also some long-term changes that are going to be happening in the blood vessel structure. There are going to be some changes happening in the functioning of some crucial hormone systems, and this may predispose the individual to developing hypertension later on in life. Some environmental factors include obesity, alcohol intake, salt intake, stress, even a sedentary lifestyle. This is very common among medical students, very common among workers, office workers. Then, of course, smoking has also been implicated. So there has also been some evidence that people that take diets that are high in potassium can actually protect themselves against the effects of high sodium. But of course, this is to some extent, because if you push your potassium levels way too high, you may result in having an arrhythmia or your heart may indeed stop. Moving on to secondary hypertension, which is the less common variant, it accounts for individuals that are having this, that are below the age of 30, with hypertension that is not controlled sufficiently by 3 drugs. So if you get this patient that is below 30, you start them on antihypertensive, and regardless of you starting them on antihypertensive, the blood pressure still remains uncontrolled. Then they should be investigated for these secondary causes of hypertension. In actually all the patients that you see that you suspect hypertension, at least try and take a full history, examine them adequately, and order the appropriate investigations in order to find out what may be causing this hypertension. And some of the secondary causes of hypertension include renal causes, endocrine causes, adrenal causes, cardiovascular causes, neurogenic causes, drugs, and other miscellaneous causes. We'll begin with renal causes. You could have conditions like chronic kidney disease, chronic pyelonephritis, diabetic nephropathies, acute and chronic glomerulonephritis, chronic tubular interstitial nephritis, polycystic kidney disease. You may have urinary tract obstructions. You may even have renal vascular disease, like for example in renal artery stenosis, which is much more common in young adults and in young individuals than in older adults. Then, of course, you may have a renin-producing tumor. Remember that renin is part of the long-term control of blood pressure in a system that is referred to as the renin-angiotensin-aldosterone system that I will talk about in depth in the next video on internal medicine when we discuss heart failure rather. Then the next common causes are endocrine, so it could be due to Cushing's syndrome. Remember, it can be due to Cushing's disease or Cushing's syndrome, which is pretty much hypercortisolemia. So there's a lot of cortisol that's present in the blood. And if you're talking about Cushing's disease, it means that the elevation or the ACTH that is being produced in excess is coming from the pituitary gland. If you're talking about Cushing's syndrome, that means the ACTH is coming from elsewhere outside the pituitary gland. You may also have a condition that's known as acromegaly, where someone produces excessive growth hormone, hyper and even hypothyroidism. I know this may come as a shock to some of you, but hypothyroidism can also cause hypertension. I want you guys to search on this and actually read up on it and drop a comment in the comment section below on explaining how hypothyroidism causes hypertension. And if you do get it right, I will give you a shout out in the next video. And then of course you may have hyperparathyroidism that may cause hypertension. There are some adrenal causes such as hyperaldosterolemia, which is known as Cohen's syndrome. You may have a tumor of the adrenal medulla that is producing catecholamines, that is referred to as a pheochromocytoma. You may have adrenal hyperplasia. Some cardiovascular causes include coarctation of the aorta. Remember, when you examine this patient, you may get a radio or a radiofemoral delay when you palpate the pulse. Then you may have vasculitis, even some collagen vascular diseases. Neurogenic causes include psychogenic. It could be a psychogenic factors that may be leading to a secondary hypertension. You could have increased intracranial pressure. You could have acute spinal cord section injuries. You may have some drugs such as NSAIDs, combined oral contraceptive pills, cyclosporine, and nasal decongestants, steroids, and even adrenaline and other beta agonists that may cause an increase in the blood pressure. Other causes include obstructive sleep apnea and indeed pregnancy, or you can be associating it with preeclampsia and eclampsia, which is an elevation in blood pressure associated with pregnancy. So according to the degree of elevation, so there are some recommendations that were made from the 7th report. I think there should even be an 8th report right now of the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, the JNC7. There should be a JNC8 now that classifies the BP in adults that are aged 18 and above as follows. So you have individuals that are normal, those that have a blood pressure that is less than 120, systolic and diastolic less than 80. And you have those individuals that are pre-hypertensive. So these are not really hypertensive individuals, but they have the potential of becoming hypertensive. So individuals between the range of 120 to about 130 millimeters of mercury systolic blood pressure and a diastolic blood pressure of 80 to 90. Then those at hypertension stage 1, you have a systolic blood pressure of 140 to 159 systolic and a diastolic blood pressure of 90 to 99 millimeters of mercury. Then those at stage 2, that if they have a blood pressure that's greater than 160 millimeters of mercury systolic, or diastolic blood pressure that's greater than 100 millimeters of mercury. But according to the American College of Cardiology and American Heart Association, as of 2017, they removed the pre-hypertension stage according to their guidelines. So they just have pretty much an elevated BP, which is a systolic blood pressure between 120 to 129 and a diastolic blood pressure less than 80. That's referred to as an elevated BP. And then a stage 1 hypertension, a systolic blood pressure between 130 to 139 and a diastolic blood pressure between 80 to 89. But this is a bit confusing. So this is the American College of Cardiology as well as the American Heart Association. So this is the table with the normal, elevated, stage 1, stage 2, and of course hypertensive crisis over there. So take your time to learn these values, but I wouldn't advise you to learn this table for your exam. The table that I want you to know and keep in mind is this classification that I'm about to show you right now. So someone who has a blood pressure that is less than 120 systolic and less than 80 diastolic, that is optimal. And then someone who has a blood pressure between 120 to 129 and 80 to 84, that's considered also as normal, okay? A higher degree of normal. Then those that have 130 to 139 as well as 85 to 89, you consider these as pre-hypertensive. This was removed from by the American College of Cardiology, as well as the American Heart Association. Then hypertension is now having mild hypertension or stage 1, 140 to 159 systolic, 90 to 99 diastolic. Stage 2, which is 160 to 179 systolic, 100 to 109 diastolic. And stage 3, greater than 180 systolic, greater than 110 diastolic. And then sometimes you may have isolated systolic hypertension, where you have an increase only in the systolic value, whilst the diastolic value remains less than 90. So if you have 140 to 149, that's stage 1, greater than 160, you refer to that as stage 2. Now, sometimes you may get different stages, like for example blood pressure readings that fall under different stages. Like for example, if someone has a blood pressure of 165 over 95, so the 165 systolic is falling under stage 2, but the 95 is falling under stage 1. So we usually put them at the higher stage, the value with the higher stage. So the person would be at stage 2 hypertension. So that is what I am talking about here. So when the systolic and the diastolic pressure fall into different categories, the higher category should be selected. For example, if you have 160 over 92, this person should be at stage 2 hypertension. If you have 174 over 120, this person should be at stage 3 hypertension. And remember that the progression of hypertension is going to go as follows. So a person is going to start off as being pre-hypertensive. This may actually be as early as a person that's aged 10 to about 30 years, where we may only see an increase in the cardiac output. Then this person may progress to having early hypertension, especially in individuals between the age of 20 to 40 years. So they may have increased in peripheral resistance, and then they're going to progress to them having hypertension between the years of 30 to 50 years. And finally, they may even develop complications of hypertension if they're aged 40 to 60. This is like the natural progression of the disease if the individual doesn't receive any treatment at all. Then some important terms that I want you to take note of, because these are very important, especially when it comes to the management of these emergencies. So there is what is referred to as hypertensive urgency, what is referred to as hypertensive emergency, malignant hypertension, hypertensive crisis, accelerated hypertension, as well as burnout hypertension. So we'll begin to talk about hypertensive urgency. So this is where someone has a very high blood pressure, their diastolic is greater than 130, but they do not have features of end organ damage. So there are no complications that are present. So when we're lowering the blood pressure, we should lower the blood pressure over 24 hours. So it should be lowered slowly. So it's urgent. It's not really an emergency. Then hypertensive emergency, this is where someone has a very high BP, a diastolic blood pressure that's greater than 130, and they have end organ damage. So here the BP should be lowered very quickly. Within hours or minutes to about hours, we should lower the BP. And unless usually it doesn't occur unless you have a sudden increase in the diastolic blood pressure greater than 130. And it was previously referred to as malignant hypertension. But now the term malignant hypertension is only used when you have these hypertensive crises that are associated with papilloedema, which is a characteristic change that you see in the eye, in the fundus of the eye. So some signs of end organ damage include encephalopathy, which may present as headache, visual impairment. Sometimes they may have seizures. Focal neurological deficits are not so common with encephalopathies. Then you may sometimes get blurring of the vision, which may be due to retinal hemorrhages. You may get some chest pains or angina. You may get heart failure or features of heart failure. You may get pulmonary edema. Sometimes you may get aortic dissection, which is going to be this sharp piercing chest pain right in the center of the chest. You may also get acute kidney injury. Then hypertensive crisis is just simply a diastolic pressure that is greater than 130, and you have fundoscopic findings of papilloedema. So sometimes you may have change in the neurologic as well as the mental state, and you may have abnormal renal sediments that are present in the urine, and these are usually the hallmark of hypertensive crises. Then if it's associated with retinal hemorrhages or retinal exudates, you refer to that as accelerated hypertension. Sometimes you may have an individual that has had hypertension that has been severe for a very long time, but then this has progressed now to congestive cardiac failure, and the ventricles have also dilated. So it means that they're going to have decreased systolic function, and when you measure the BP, then you may sometimes see that the BP now is low or even normal. So you refer to that as burnout hypertension. So take note of these terms because they are very important to distinguish clinically, because how we're going to be managing them differs largely. So according to the pathophysiology of hypertension, we do not know so much. So there are a combination of factors that are already alluded to when I was explaining on the first slide. So you may have things like changes in cardiac output that may increase, which are due to, like for example, increase in the stroke volume, which may be caused by retention of sodium and retention of water. It may be due to problems with the heart rate, where you have hypersensitivity of the centers that are supposed to be stimulating the heart, the receptors that are responsible for the control of the heart rate. Then sometimes you may have changes in the peripheral vascular resistance. You may have sodium retention that is of course regulated by the renin-angiotensin system that will be covered in the next video. Some risk factors include non-modifiable risk factors and modifiable risk factors. By non-modifiable, meaning that there's pretty much nothing you can do about. There's nothing you can do about your age. There's nothing you can do about your gender. You can now. There are some people that are changing from male to female, but underlying genotype will always be a male, no matter the organs that you change in the phenotype. Then, of course, race, we say that they are much more common in black individuals than they are in Caucasians and white individuals. Then some modifiable risk factors include arteriosclerosis, which is thickening of the arterial walls, dyslipidemias or hypercholesterolemia, diabetes mellitus, smoking, obesity, sedentary lifestyle, excessive salt intake, excessive alcohol intake. You can also have stress and a type A personality. So these are pretty much workaholics. They are outgoing, ambitious, they are rigidly organized, they are they are impatient, highly status conscious, they are anxious people, proactive, and they are usually concerned with time management. So they're usually worried about so many things, and they're very competitive. So this puts an individual at a risk of hypertension. So if you know an individual that's like that, tell them to take a chill pill. Then some clinical features of hypertension. Remember that I told you that this is a silent killer because most of the patients are asymptomatic. So they may not know that they have hypertension until maybe they fall down with a stroke or they actually die. And you may not even know what has killed them. Some people will blame it on witchcraft and say, no, because it was an uncle at a village that hated this person. That's why this person fell down and died in church. So some symptoms include things like a headache. This is mostly associated with high blood pressure, but it sometimes may be present even in a person with hypertension. So it may be localized to the occipital region, and usually it is worse when this person wakes up in the morning because the BP is usually higher in the morning, but it spontaneously subsides after several hours. Then, of course, contrary to the belief of the advice that you give people that are hypertensive, you tell them to drink water. Water is not the fix. Water will only make things worse. So not every headache is equals to water. Not every increase in blood pressure is equals to water. Then, of course, you may get other features like a blurred vision. You may get postural hypotension. You may have dizziness. You may have palpitations, which is an undue and an unpleasant awareness of cardiac activity. So right now, as you're seated, you can't feel your heart beating. But if you start feeling your heart beating and it starts hurting, you refer to that as a palpitation. So sometimes you may have shortness of breath. You may have sweating. You may have easy fatigability and even impotence. Some signs on physical examination include tachycardia, features of cerebrovascular insufficiency, lung crepitations, even hypertensive retinopathy, which we shall grade very shortly. Some features may also be attributed to end organ damage. Remember that hypertension can affect the CNS, it can affect the eyes, it can affect the heart, it can affect the kidneys, it can affect the blood vessels. So you may have epistasis, which is nose bleeding. You may have hematuria, which is blood in urine. You may have retinal changes like blurring of the vision. You may have cerebrovascular disease, like for example transient ischemic attacks. You may have strokes. You may also have some cardiovascular system problems like chest pains. You may have a prior myocardial infarction. You may even have pain that may be due to a dissecting aorta. or dissecting aortic aneurysm. Then some other clinical features may be due to the underlying cause, like for example in secondary disease. Like for example, if an individual has hyperthyroidism, they'll also have features of hyperthyroidism. So they may have the goiter, they may have sweaty palms, they may have exercise intolerance, they may have heat intolerance, and so on and so forth. But what you really need to note is that the only reliable feature that's going to be pointing you towards hypertension is indeed the blood pressure. So here are some of the other clinical features that you may see in some conditions that are present. So this is not really an exhaustive list. It's just to give you an idea of how you should tailor your reading and actually know your stuff. So you may have chronic pyelonephritis, which will give you a history of repetitive UTIs. You may have pheochromocytoma. Remember, this is a tumor of the adrenal medulla producing catecholamines. You may have a history of sweating, labor hypertension, headaches, nervousness, postural dizziness, palpitations, and even weight loss. Then you may have aldosteronism, which will present you with a history of polyuria, polydipsia, muscle weakness. That is obviously secondary to hypokalemia. Remember, whenever you retain sodium, you lose potassium. Then you may have Cushing's syndrome that will give you a history of weight gain as well as emotional liability. Okay. Then, I don't think there's liability. But anyways, and then you may have features of hypo or hyperthyroidism, like I said, history of cold or heat intolerance, sweating, lack of energy, bradycardia or tachycardia. Some drugs, of course, you ask for a history of this person taking any oral contraceptives, Leucoris, or even sympathomimetic drugs. Then there may also be a history of a patient having a known renal disease or an abdominal mass or anemia or even urochrome pigmentation. So when we make a diagnosis of hypertension, we should have an elevation of the BP on 3 separate occasions. And take note that in pregnancy, it's about 4 to 6 hours. So we do not want to tell this woman, go home and come back another day, because she may come back and the fetus is dead. Worse off, she may go and she may die. So some tests that we may want to order, you may order a full blood count with a differential count to rule out any infections, like for example in chronic pyelonephritis, and anemia also to rule that out, as it can exacerbate heart failure or tip the patient into heart failure. Then you want to do a urinalysis microscopy, culture sensitivity for any UTIs, check for proteinuria, any blood glucose for any glomerulonephritis or glomerulopathies, check for the random as well as the fasting blood sugar to rule out diabetes mellitus, check for the urea, electrolytes, creatinine to check for kidney function, the electrolytes, especially sodium, to be ruling out any evidence of primary hyperaldosteronism. Then also look at the liver enzymes. Check for a lipid profile, because sometimes there may be increase in serum cholesterol, there may be an increase in triglycerides, there may be a decrease in the high-density lipoprotein and an increase in the low-density lipoprotein. Remember, high-density lipoproteins are the good lipids. The low-density lipoproteins are the bad lipids. Then you may also do a chest x-ray, an ECG, and an echo. An echo may show you that there is some left ventricular hypertrophy. You may also see the features of left ventricular hypertrophy on the ECG. If you haven't yet watched the ECG videos, what are you waiting for? Just click on the playlist and have some fun. Some special tests that you may order include thyroid function tests. So you may order for your T3, T4, and TSH to rule out hypo and hyperthyroidism. You want to do a renal ultrasound with Doppler to rule out any renal vascular disease. And if you're suspecting that this individual has a pheochromocytoma, of course, you may do a 24-hour urine assay for metanephrines as well as catecholamines. If you're suspecting this person has Cushing's syndrome, you may either do a 24-hour urine cortisol or an overnight dexamethasone suppression test. Then, if this person has primary aldosteronism, you want to order for serum renin as well as aldosterone, which may be elevated. So remember that complications of hypertension could be the central nervous system complication, eye complications, the heart, the blood vessels, and the kidneys. So these are the target organs which hypertension is going to be affecting. So if we're coming from head to toe, you could have hemorrhage, you can have infarction, you can have seizures, vascular dementia, which are going to present to you as the CNS complications. You could have sometimes it affecting the eyes, but you could have hemorrhages, you could have exudates, atrial venous snipping, papilloedema, which may ultimately lead to blindness. You could have cardiovascular conditions. Remember, all roads are going to be leading to cardiac failure. Then you may have problems in the blood vessels, atherosclerosis. Remember that hypertension is a risk factor for atherosclerosis, and atherosclerosis is a risk factor for hypertension. You may also have aneurysms as well as aortic dissections. So beginning with CNS complications, you may have hypertensive encephalopathy. So you get a patient who has a very high BP. They're going to be having altered level of consciousness. They may have increased features of increased intracranial pressure, like, for example, papilloedema. They may even be having seizures. Remember, focal neurological deficits in hypertensive encephalopathy are uncommon. So this is what's going to now help you distinguish between hypertensive encephalopathy and a stroke. If someone has a stroke, they're going to be having focal neurological deficits. But with hypertensive encephalopathy, they may not have focal neurological deficits. Then you may sometimes have cerebrovascular accidents, like, for example, the transient ischemic attacks, which usually resolve within the first hour or the first 24 hours of presentation. So someone may have episodic dizziness, unilateral blindness, or hemiparesis, where they're paralyzed on one side. Then sometimes they may have stroke. Remember, there are two types of stroke: ischemic stroke, which are often due to atherosclerosis of the cerebral blood vessels, or hemorrhagic stroke, which are often as a result of elevated arterial blood pressure. Then you cause endothelial damage. You result in formation of these microaneurysms in the blood vessels that can rupture, and then you can bleed into your brain. So don't forget to order for a CT scan. You may sometimes have cerebral vascular insufficiency, even vascular dementia. Some eye complications include blurring of the vision. You may have retinal hemorrhages. You may have hypertensive retinopathy. And here's the grading below. And I want you to pay attention to this, because they will ask you this on the words. They will ask you this on your OSCE stations. They will ask you this on your theory exams. So hypertensive retinopathy is graded according to 4 grades. So you have grade 1, grade 2, grade 3, and grade 4. So in grade 1, you have what is referred to as silver wiring. So the blood vessels become shiny. So they have an increase in reflectiveness. Okay. This is often due to thickening of the arterioles. So they look like copper wiring. So we refer to that as silver wiring. And they become very twisted. As you can see, this blood vessel here on the screen, this is very twisted. So they become tortuous. So what you have in grade 1 is silver wiring plus tortuosity, increase in tortuosity. Then grade 2 is whatever you had in grade 1, plus you're going to be having this atriovenous nipping, which is often produced when you have this thickened renal arteries that are passing over the renal veins. So it's kind of like someone has nibbled away at the blood vessels. Yes, it's kind of like someone has nibbled away at the blood vessels. Then grade 3 is what you have in grade 2, plus you have this cotton wool spots, which are depicted also here. And these cotton wool spots are pretty much flame-shaped hemorrhages and soft exudates. These are often due to small infarcts. Then grade 4 is what you have in grade 3 plus papilloedema. So you have this optic disc where these vessels are coming out from. You may have a blurring of the optic disc. So what is shown here is what is seen in hypertensive grade 3. So sometimes on your OSCE stations, they may bring you this and they may ask you what you see on this image. So remember that grade 3 and grade 4 retinopathy are diagnostic of malignant hypertension. So some cardiovascular complications include coronary artery disease, ischemic heart disease such as angina pectoris, myocardial infarctions, aortic dissections, pulmonary edema, heart failure, as well as peripheral vascular insufficiency. Some kidney complications include hypertensive nephropathy and renal failure. And remember that this hypertensive nephropathy is often associated with arteriolosclerosis, okay, hyperplastic arteriolosclerosis. So you have this hyperplastic arteriolosclerosis where you have this hyperplasia of the smooth muscles that are present in the afferent and the efferent arterioles, as well as the glomerular capillary tuft, which is impaired. So this impairs the renal function. So patients may have proteinuria, they may have microscopic hematuria, and later on they may even develop chronic renal failure. So how exactly do we evaluate patients for hypertension? So we first make a diagnosis of hypertension. So pretty much we're going to be taking your history. We're going to be asking for a family history of hypertension. You're going to be asking if they're taking any specific drugs. You're going to be asking if they have any features of end organ damage that we listed earlier on. Then, of course, you examine or you evaluate this person, you assess their lifestyle, if they have any risk factors that may improve or rather worsen their hypertension, like, for example, their occupation, if they smoke, if they take alcohol, and so on and so forth. And then after that, you assess for other cardiovascular risk factors, as well as other diseases that may affect the management, like, for example, diabetes mellitus, hyperlipidemias, even smoking. Then you try and identify if there's any secondary cause of hypertension, which you may pick up on your history. You may sometimes pick up on the physical examination. Like, for example, someone may present to you with severe weight loss, sweating of the palms on examination, as well as a high BP. So you may think that this individual may have hyperthyroidism. Then of course you're going to be assessing this patient and examining this patient for any target organ damage or cardiovascular disease. So how exactly do we measure blood pressure? Remember, whenever you're doing any clinical assessment or clinical measurement, the first thing that you must always do is introduce yourself. So, hi, my name is Dr. Moses Kazevu. Can I take your BP? Or, hi, my name is such and such a person. I am from such and such a school. I have been asked to take your BP. Is that okay with you? So if the patient says go ahead, then exactly, you can go ahead. Then explain what you're about to do and gain consent, which is what I just explained to you. Then an individual, you must have several determinations that are made over a period of several weeks for you to determine that this person is hypertensive, unless if they're coming in with an end organ complication or their BP is very raised. So the patient should actually rest and be quiet for at least 5 minutes before you measure. Because an individual could have been stressed, he could have been arguing with someone, they could have been running, they could have been coming from the heat. All these things can raise the blood pressure. Then of course the cuff that you're supposed to use, because we're going to be using a sphygmomanometer and we're going to be using a stethoscope, a method which is known as the auscultatory method. So you're going to ensure that the cuff is the appropriate size, so it must be large enough, because if the cuff is too small, the blood pressure readings will be very high. If it's too large, the blood pressure readings will be very low. So the rule of thumb is that the bladder of the cuff should encircle more than 30% of the arm, and a wide cuff, particularly the one that doesn't exceed 30 centimeters, should be used. Okay, because if we have a very huge cuff, it may cause you to have low blood pressure readings. If the cuff is too small, the blood pressure readings may be elevated. And then when you now place on the cuff and you begin to inflate, you close the valve and you begin to inflate, then you're going to be listening and auscultating over the antecubital fossa, and you're going to be pumping the sphygmomanometer until you can't hear anything from your cubital fossa. Then you go at least about 10 millimeters of mercury above that pressure reading. Then you start to deflate the cuff slowly by about 2 millimeters of mercury per second, and then you're going to be listening with your stethoscope over the antecubital fossa. Then the sounds that you're going to be hearing are what are known as Korotkoff sounds. So the first sound, which is known as phase 1, is the blood pressure at which you hear this first sound. That is your systolic blood pressure. Then the sounds are going to increase in intensity in stage 2 or in phase 2. Then they are going to eventually begin to be muffled out in stage 3, and eventually they disappear. So some individuals say take the blood pressure reading, the diastolic blood pressure reading at stage 3 or phase 3, but according to the literature, it's supposed to be taken at phase 4 when the sounds actually disappear. So then do this 2 or 3 times and then get an average reading of the systolic as well as the diastolic blood pressure, and then of course thank the patient. So at any given visit, you should have an average of 3 blood pressure readings taken about 2 minutes apart using a mercury manometer preferably, and not really a digital one, because sometimes a digital one may give you false readings. Then of course the blood pressure should be taken or should be measured with the patient supine and in the sitting position. Then you should auscultate with the bell of the stethoscope. Then on the first visit, you should check that the blood pressure in both arms, so both the right and the left arm, as well as in one of the legs, to avoid missing out any coarctation of the aorta or any subclavial artery stenosis. Now, last but not least is the management of hypertension, which can be divided into 2 main groups. You have non-pharmacological management and you have pharmacological management. So in non-pharmacological management, the goal of this is actually to reduce the blood pressure to less than 140 over 90 millimeters of mercury, or ideally less than 130 over 80 millimeters of mercury in patients with diabetes or patients with renal disease or even patients with cardiovascular disease. So in all patients that have pre-hypertension, in patients with stage 1 and stage 2 hypertension, you should counsel them for some lifestyle modifications. I will tell you about the measures that they should do in the next slide. And the patients with mild to moderate hypertension, meaning grade 1 and grade 2 hypertension, you should give them at least about 3 months to respond to these behavioral modifications in order to see if they may help. Sometimes they do help and they may actually not even need medication. But if you try this and the non-pharmacological therapy fails, then medication should be added, especially for those in hypertension stage 1 and stage 2. But in general, if someone comes in with hypertension stage 3, if they come in with signs of end organ damage, like for example a stroke, stroke, chronic kidney disease, coronary artery disease, congestive cardiac failure, or any retinopathy or any other complication of hypertension, they should be started on antihypertensive immediately. And you should counsel this patient that these drugs are going to be taken for life. There is no curing of hypertension unless you determine the underlying cause and address the underlying cause. Once that has been addressed, then the hypertension will also abate. Then there are other modifiable cardiovascular risk factors that should be treated and screened for, things like diabetes mellitus, hyperlipidemias, as well as smoking. So some measures that we're going to be taking non-pharmacologically, we pretty much tell them to regulate the salt intake. So the intake should not be more than 2.4 grams of sodium or 6 grams of sodium chloride. So you should not add any salt over the table. You should have a low sodium diet because salt or sodium attracts water. If you've ever left salt open overnight, just do this experiment tonight. Get some salt, put it on the table, leave it overnight. When you come back in the morning, you find that it's wet because it's hygroscopic. It draws water towards it. Then you advise them to participate in some weight reduction, of course, according to what they can tolerate. Ideally, the BMI should be between 20 to about 25. You also tell them to have some exercise, so aerobic physical activity, to what they can tolerate. Do not push a patient to exercise to a point where you tip them into heart failure. That's doing more harm than good. So a brisk walk for about 30 to 45 minutes most of the days of the week, about 3 to 4 times a week, may be sufficient enough. If they take alcohol, you tell them to decrease the consumption of alcohol, less than 3 units per day for men, and then less than 2 units per day for women. And then, of course, alcohol is known to potentiate catecholamines and exacerbate hypertension. But according to me, if it was up to me, I would actually tell my patients to stop drinking alcohol because there is no benefit of actually taking excessive alcohol. And you tell them to also stop smoking if they are smoking. Then if they are stressed all the time, there are some stress relaxation techniques that they can take up. They may go to a massage parlor. They may go swimming, okay? They may go on a trip and just relax and loosen up. Then also advise them to have a DASH diet, which is dietary approaches to stop hypertension. So a diet that's going to be rich in fruits, vegetables, low-fat dairy products with decreased saturated as well as unsaturated fats. So take note that when a patient is actually starting medication, they should be counseled that they will likely need this medication every day for life. And sometimes most people may think that because I'm feeling okay, I don't need to take the hypertensive drugs, but that's not true. You should take the drugs even when you're not feeling well. You should take the drugs when you're feeling unwell. You should take the drugs when you're feeling well. So some of them may have some side effects, and if they do have side effects, they should notify their doctor, and they shouldn't just stop the medication until they're seen by a doctor. So you make sure that you counsel your patients on that. Now, when it comes to the pharmacological therapy, there are some commonly used drugs to treat hypertension. You have ACE inhibitors, which block the production of or the conversion of angiotensin 1 into angiotensin 2. Remember, but this is an enzyme which is known as angiotensin converting enzyme. Another function of this enzyme is to break down bradykinins into inactive compounds. So it means that one of the major side effects that is seen with ACE inhibitors is a dry cough, because sometimes you may have this bradykinins that are supposed to be broken down by these ACE inhibitors accumulating in the lungs. Then you also have an alternative to this, which are angiotensin receptor antagonists that don't have this side effect of the cough. Then you may have beta blockers, calcium channel blockers, and diuretics. So A is signifying ACE or angiotensin receptor antagonist, so ARBs or ACE. B is for beta blockers. C is for calcium channel blockers, so things like nifedipine, amlodipine, those that work on blood vessels. Then you also have diuretics here. So the management is going to be occurring in steps, step 1 up to step 4. And if the blood pressure remains elevated despite you having a maximum dose of the first drug, then you can add another drug and then titrate that drug to the maximum dose, just like that. If 2 drugs you have titrated them to the maximum dose and still there's no response, you can add a third drug. So the steps are as follows. So you have an individual that is younger than 55, or you also have an individual that is older than 55, or a black individual of any age. So an individual that is younger than 55 and is white or Caucasian or whatever it may be, they respond very well to ACE inhibitors. Black individuals have very low concentrations of renin, so usually drugs that work on the renin-angiotensin system do not really work so well. So if the you want to start them on a drug, start them on ACE inhibitors. Then patients that are 55 years and older, start them on calcium channel blockers or diuretics. So if step 1 doesn't really work, then you can elevate to step 2, where you're going to now be combining ACE inhibitors plus a calcium channel blocker, or ACE inhibitors plus a diuretic. If this fails, you can combine ACE inhibitors, calcium channel blockers, and a diuretic. Then if this fails, then you can add another diuretic, or you can add an alpha channel blocker or a beta blocker. At this stage, you should actually see a specialist. Then in step 1, so like I already told you, young Caucasian individuals are more likely to have high renin. Black individuals have low renin concentrations, so it means that black individuals are not going to tolerate drugs that are working on the renin-angiotensin system. So it's better to start them on either diuretics or calcium channel blockers. But then the white individuals, they can be started on ACE blockers or angiotensin receptor antagonists. And of course, if a drug with each pair is not really tolerated, the alternative drug can be used. Like for example, if someone has side effects from ACE inhibitors, they can give them ARBs as an alternative. And if a drug is not effective, you can select a different drug from another group and try it out. Then of course, a calcium channel blocker, if it's not helpful, then you can try an ACE inhibitor or an angiotensin receptor antagonist. And almost all patients will need more than one drug to effectively lower their blood pressure. There are some who actually do respond to just one drug. Then, so here are the options that you can have. So you can start with diuretics, amlodipine, and hydrochlorothiazide in a combination of 5 to 50 milligrams. That's once a day orally. Or you can do hydrochlorothiazide 25 milligrams once a day, or spironolactone 25 to 50. But this has a side effect of causing gynecomastia. Then you can take this twice a day or 4 times a day. And option 2, which is the more common option that's used, you can start them on calcium channel blockers, nifedipine 20 milligrams twice a day, or amlodipine 2.5 to 10 milligrams once a day. Or option 3, you can use angiotensin converting enzyme inhibitors such as captopril 25 to 50 milligrams twice a day orally, or 3 times a day, or alternatively enalapril. That's 2.5 to 40 milligrams once a day. And of course, those that can tolerate ACE blockers can be given angiotensin receptor antagonists, losartan 50 to 100 milligrams once a day. Then step 2, you're going to be combining 2 drugs from different groups. So either angiotensin receptor blockers plus calcium channel blockers, or angiotensin receptor blockers plus diuretics, or angiotensin receptor or calcium channel blockers plus ARBs. Then step 3 is you're going to now be combining an ACE or an ARB with a calcium channel blocker plus a diuretic. And if the 3 drugs are not yet sufficient to actually manage the hypertension, you may add an alpha blocker, you may add a beta blocker, or spironolactone, or any other agent that's a hypertensive. But usually we do not advise individuals to combine diuretics with beta blockers, because this can exacerbate diabetes. Then in step 4, that's where you add either another diuretic. We can add an alpha channel blocker. We can also add a beta blocker if, of course, they're not optimized. But at this point, I'm sure you would have already referred them to a cardiologist. So you may give them alpha blockers, prazosin 0.5 milligrams twice a day or 3 times a day initially at bedtime, because it may cause postural hypotension. Then, of course, you can increase this by 1 to 3 milligrams twice a day or 3 times a day after 3 to 7 days, with a maximum dose of 200 milligrams. Or you can add a beta blocker, atenolol 50 to 100 milligrams once a day, or propranolol 40 to 80 milligrams twice a day or 3 times a day, or hydralazine 25 to 50 milligrams. But these drugs usually cause hydralazine, especially drops the BP very fast. Then beta blockers are not used routinely to treat patients with hypertension as initial therapy. However, they can be used in young individuals, and they actually lower the risk of developing cardiovascular problems as well as ischemic heart disease. So a side note that you need to take is that some calcium channel blockers such as nifedipine are very good in Africans, and they are good to start off as the first hypertensive drug if you want to lower the BP rapidly, especially in hypertensive urgencies. For patients with diabetes and congestive heart failure, and those that are normal or have a stable creatinine level, ACE inhibitors are the best first line. For patients with coronary artery disease, beta blockers are very good to start with. And most hypertensive drugs are going to be taking about 2 to 4 weeks to reach their maximum effect, so you should wait at least a month to actually increase the dose of the drug or before adding another drug. So here's a summary of the drug. You can pause the video at this time. I won't go through this table because it's very exhaustive. So you can actually have a look at each of this drug, the dosages, the conditions in which they favor, and the contraindications or the cautions that you should look out for. Have a lot of details of this. Same thing with this. I have pretty much listed everything that you need to know about the important classes of drugs and the important considerations that you should go through. So you may pause the video here and actually take notes. I think everything should be self-explanatory. Same thing about here. This is still just the other drugs that are given in antihypertensive patients. The last and final thing that we'll talk about is management of the hypertensive crisis. Remember, we talked about hypertensive urgency, hypertensive emergency, hypertensive crisis, as well as burnout hypertension. So I will not go through this over again. I just put this slide here to remind you of what they meant. So when we are managing a patient, so we want to assess the patient rapidly with a brief history and a targeted physical examination where you examine the CNS, you examine the cardiovascular system, you examine the retina, you order some labs like a full blood count, a urinalysis, renal function test, an ECG, and an echo. Then, of course, some general measures that you may do. If the patient is in a stressful situation, you should place the patient in a quiet room and you evaluate them after the initial interview. Some patients' BP may lower when they actually relax. Then, if the patient has an hypertensive urgency, which means there are no features of end organ damage, you can aim to actually lower the mean arterial pressure by 25% over 2 to 3 days. So you lower the BP over days. So a good way to lower the BP is about giving nifedipine 20 milligrams orally twice a day. You may add other medication if necessary. But if the person has an hypertensive emergency where there are features of end organ damage, you want to lower the MAP by 25% over 1 to 2 hours. So we use intravenous medication. So we use intravenous medication, but we should not drop the diastolic blood pressure to less than 95 millimeters of mercury. So what is mean arterial pressure? You can calculate the mean arterial pressure by using one of these formulas, either diastolic pressure plus 1/3 systolic pressure minus diastolic pressure, or you can use this 2/3 of diastolic pressure plus 1/3 of systolic pressure. This is one of the easy formulas to use, or 2 multiplied by the diastolic pressure plus the systolic pressure, divide everything by 3, or you can say the diastolic pressure plus 1/3 of the pulse pressure, where pulse pressure is the systolic pressure minus the diastolic pressure. So you can calculate this to know your normal mean arterial pressure. Comment on the comment box below to tell me what's the normal mean arterial pressure. So here are some pharmacological interventions that you can use to manage hypertensive emergencies. So you can start with labetalol 50 milligrams IV given over at least a minute. You can repeat after 5 minutes if necessary, and your maximum dose is 200 milligrams. Hydralazine is what we use commonly in our setting, so you can give a start dose of 10 milligrams IV followed by a 5 milligram IV every 30 minutes until your diastolic pressure is less than 110. And then after it's less than 110, you can now transition them to nifedipine 20 milligrams twice a day. Then you may also give sodium nitroprusside 0.5 to 8 micrograms per kg per minute through a continuous IV infusion till your blood pressure is lowered to the desired level. Additionally, you can add an adjunct of furosemide, which is a diuretic, 40 to 80 milligrams intravenous, and then as the BP stabilizes, then you can start this patient on oral antihypertensive agents. And of course, these patients with hypertensive urgency should be followed up closely after discharge, and they should also be given oral medication. Thank you for taking your time to listen to this long lecture on hypertension. I hope you understood everything that you need to know about hypertension, its management, as well as the management of the hypertensive crisis, because it's a very, very common thing that you'll see on the wards on an everyday basis. If you haven't yet subscribed to the channel, subscribe to the channel, drop a like, drop a comment, and show some support for the YouTube algorithm to